everyone. I'm speaking to you from Cat Island in the Low Country. Before I get started, I'd like to thank Dr. Walker for the invitation to participate in this educational series. I'd also like to thank the NCBH team for making it all happen. The title of this talk is The Prevalence of Venous Disease and the Drivers of Associated Costs. Disclosures, none that are relevant to this discussion. So venous disease, we have the chronic form, CVD, and the acute form, venous thromboembolism, VTE, which is comprised of DVT, deep vein thrombosis, and pulmonary embolism, PE. In 2020, if we look at the US prevalence of selected chronic diseases, we see something that's amazing. Chronic venous disease at 180 million dominates even diabetes at 34 million. Looking at varicose veins, we have a US prevalence of 54 million out of that 180 million. Symptoms: heaviness, tiredness, tenderness, itching, aching, pain, and swelling, but this may be asymptomatic disease. And varicose veins are not just a cosmetic problem, but a manifestation of chronic venous insufficiency that is CYP3 to 6. Varicose veins progress to more severe disease, including ulcers, at a 2 to 4% annual rate in low-risk patients, but at a 5 to 8% rate in high-risk patients. We look at the current treatment patterns. This is from the MarketScan database, real-world treatment patterns. We see that 70% are treated with surveillance with or without compression, and 30% are treated with interventional therapy. And the biggest single category is only 10%, which is laser. Looking at the costs and consequences in this real-world database, we see that 1.8% of treated patients developed ulcers at 1 year. At 2 years, the disease progressed in 25 to 43%. Remember, these are varicose vein patients. High percentage needed additional treatment at 2 years, over half. And per patient treatment costs in 2012 were $204 for surveillance with without compression, and interventional therapies ranged between $4,000 and $5,800. Varicose veins increase the risk of DVT. Two recent studies found that varicose increased the risk of DVT by 5 to 7 times. And the question in my mind is, would early treatment of varicose veins reduce the risk of DVT? And if so, which treatments might do so? An economic case can be made for early intervention in varicose vein patients. And here, early intervention was less than 2 months, intermediate was between 2 and 6 months, and late was 6 months up to 24 months. And what was found that treatment at earlier stages increases the cost. So early treatment costs $17,600. Intermediate treatment costs a little bit more, but late treatment costs $18,400. Likewise, disease progression was lower, much lower in the early treatment group. So 29% progressed in the early treatment group, but over half of those in the late treatment group progressed in their disease. Turning to venous ulcers, annual incidence of 1 to 2 million. Incidence increases with age, so that this is very much a disease of the elderly. Venous ulcers, we estimate the treatment cost of 21 to 46 billion. Now that's significantly higher than the 1.5 to 3 billion that you see frequently quoted in the literature. The difference is twofold. One, higher incidence of disease, but more importantly, this estimate is based on current US treatment costs of current US therapies. The 1.5 to 3 billion estimates are based on 1980s data, cost, treatment modalities in Europe, I think specifically Germany and the UK. You also frequently see that venous ulcers cost between 1 and 3% of national health expenditures. If you do the math, it's 30 to 90 billion. Comparing the 21 to 46 billion with that range, It's actually at the very low end of that range. So it may not be such a crazy number. Looking at the annual economic cost of incident disease, venous ulcers, $38 billion, compared with $21 billion for diabetes. That's not just diabetic ulcer, it's diabetes. Alzheimer's, $18 billion, cancers, 11. Venous ulcer costs are primarily outpatient, 43%, and then another 35% are home health care, nursing, and dressings. Venous ulcers reduce productivity and increase costs. Venous ulcer patients in one study lost 40% more workdays, or 14 days a year on average, at a cost of $2,700, and about 70% of these patients were female. Venous ulcers reduce quality of life. Ulcer treatment is viewed as burdensome and time-consuming. Patients experience chronic pain, which leads to sleep loss. There's reduced mobility in 80 to 90%, which leads to problems with daily living. Self-care, inability to work, and inability to exercise. There's odor, swelling, and discharge. This all leads to a very negative emotional impact, fear, depression, and social isolation. And physical impairment is ranked similar to that with congestive heart failure and chronic lung disease. Venous ulcers have poor healing rates. At 6 months, 35 to 50% are unhealed. At 2 years, 20% are unhealed. Poor healing increases the cost. Monthly treatment cost is $2,900. Every month that goes by that the ulcer isn't healed, the costs increase. In this study, they looked at the cost of healed versus non-healed ulcers. An unhealed ulcer costs almost $38,000. A healed ulcer costs about $12,000. The EVRA trial looked at early endovenous ablation and found that it results in faster ulcer healing. This is a randomized trial of 450 venous ulcer patients, compared early endovenous ablation plus compression with compression and deferred endovenous ablation. And deferred meant after the ulcer's healed or 6 months after randomization. Results: early intervention group had shorter time to ulcer healing, higher percentage of patients with healed ulcers. Costs at 1 year were similar in pounds, pounds for both, but the endovenous patients had significantly higher QALYs, and the authors concluded that there was a very high probability, almost 90%, of early endovenous ablation being cost-effective at UK conventional cost-effectiveness thresholds. Venous ulcers are highly recurrent. 1-year recurrence rates of 20 to 40%, 5-year recurrence rates of 50%. The risk factors for recurrence: the type of therapy, compression alone without surgical correction of venous insufficiency, longer ulcer healing time, location of reflux, deep venous insufficiency present, and presence of PAD or rheumatoid arthritis. Recurrent ulcers cost more. In this study, recurrent ulcers cost over $14,000 versus $12,000 for non-recurrent. VTE. Between 900,000 and 1.1 million cases, that's the prevalence. Clinical presentation is DVT in 60 to 70%, PE in 17 to 30%, and both in 11 to 15%. 30-day mortality is very high, 10 to 30%, and up to a quarter of these cases present as sudden death. Result: 600,000 to 100,000 VTE deaths annually. VTE are preventable. It's been shown that adequate prophylaxis reduces fatal PE by over 60% and DVT by over 50%. 60% of the cases are hospital or nursing home patients. Over half of hospital patients and over 90% of major surgery patients are known to be at risk for VTE, yet only 33 to 60% of hospital patients receive adequate prophylaxis. Economic cost of incident VTE, direct medical cost, in all cause costs, 17 to 38 billion has been estimated. Then the specific cost of VTE, the incremental costs as they're called, 7 to 10 billion versus patients, control patients. And again, emphasized that 40 to almost 60% of these are preventable costs. There's also an estimate for indirect costs of premature years life lost, of 7 to 13 billion. So this is also a very costly disease. Looking at VTE costs, they're primarily inpatient in contrast to the chronic disease. Approximately 75% are inpatient costs for both commercial and Medicare patients. VTE are highly recurrent. At 1 year, 4 to 15% recurrence rates. At 10 years, a third. Recurrent VTE costs 2.2 to 3.4 times more. And that reflects increased hospitalizations, length of stay, ER visits, and total costs. Recurrent VTE costs $12,000 more in one study and more than a primary VTE. Complications increase cost. Post-thrombotic syndrome occurs in 30 to 50% of DVT patients. Heparin-induced thrombocytopenia in 0.5% to 5%. Chronic thromboembolic pulmonary hypertension in 1 to 5%, and bleeding in 1%, approximately, both major and minor. And each of these complications adds to the cost. For example, PTS adds between $1,000 and almost $8,000. HIT adds between $5,000 and $7,000, etc. And if you look at a major bleed, the cost can be $10,000 to over $23,000. Finally, looking at VTE in cancer patients, cancer accounts for 20% of new VTE events in the community. And cancer increases the risk of VTE. It's higher in patients undergoing chemo. The risk is 6.5 times. But in those not undergoing chemo, the risk is 4.1 times. And the incidence of VTE varies with the type of cancer. Pancreatic, brain, lung, digestive cancers, and lymphoma have the highest risks. And cancer patients with VTE have a much higher risk of death than those without. And finally, in cancer patients, VTE increases mean total cost by almost $23,000. So conclusions, at 180 million, venous disease is the most common chronic disease. Varicose veins are a serious disease, not just a cosmetic disease, progressing to more severe disease, including ulcers at a 2 to 8% annual rate. 2 million venous ulcers cost $38 billion annually. VTE is costly between 17 and 38 billion in all-cause costs, and incremental costs of 7 to 10 billion. The majority of VTE occurs in the hospital, but it's not adequately prevented. And recurrent VTE and complications add significantly to morbidity, mortality, and costs. And finally, more research is needed on costs and economics of venous disease. Thank you.